everybody. Thank you so much for spending part of your busy day with us. I'm here. I'm Megan Wimmer, Associate Director of Health Economics and Outcomes Research for BD, and I'm so honored to be joined by Dr. Scott Miskovich, who is the President and Founder of Premier Medical Group USA, one of the largest global providers of outsourced COVID-19 testing services, and Dr. Jeff Andrews, who is the Worldwide Medical Director for Molecular Diagnostics at BD, very large, one of the largest global medical technology companies in the world. And the reason that I'm so thrilled to be joined by them is to hear from them about their expertise in COVID-19 testing. Before I jump in with the questions, though, I just have to say to this audience, thank you for your continued support and work during this really challenging time. Probably not what you expected as elementary school principals and education staff. So definitely, I know it's been a tough ride, and thank you for what you've done so far and what you're going to continue to do. With that being said, I'm going to ask Dr. Scott Miskovich this first question, which is just to get us started. Can you tell us a little bit about what you do and how you've helped schools and various other organizations around the country stay safe?
Thank you, Megan and Jackie, and thanks for the organization for having us. And I'm honored to be here. We were all chatting a little bit before, and I mentioned that I'm a son of a 35-year elementary school science teacher. So this is very close to me. And I lived in the school environment. I'm the president and founder of Premier Medical Group. So I've been a practicing family physician for years. And I had, fortunately, the first 10 years of my career was spent working as a civilian in the military, which prepared me with security training to do COVID work and quarantine and isolation. I then was asked by some of these former people I work with that were now generals to come and support them across the country with their activities. So I began supporting COVID actually back in January, a year ago, before it even came in the country, and was preparing before COVID hit. One of my big honors was I was chosen as the medical director and the COVID director for the SEC, the Southeastern Conference, all the colleges and universities, which everybody knows. Some of you probably love them, and some of you probably say, "Oh no, not Alabama." And then it just moved on from there. And during this time, one of my final bookends to that, I was chosen as the COVID medical director for the US Olympics. So I was testing all of the US Olympic teams in their trials all the way up to Tokyo. It's important to mention that because during that time, our group has performed nearly 5 million COVID tests, and probably 1 million of these are the rapid antigens. Again, I don't work for BD. I'm an independent physician that stepped up, but I was able to use all of the tests available out there. And I always make a decision based on what is best for the country and what is best for the people. And that's how I basically used the 4 top tests and came up with BD, which is our preferred test because of its accuracy, low numbers of false positives, which the View has just made very popular, very low number of those, and it's very accurate, both in surveillance testing and testing for positives, very accurate. And the US Olympics had the choice to choose any test they wanted, and they chose BD for the rapid. So we were doing rapid testing on the athletes as they were coming in. Now, I also have honored, we have 4 states that 3 of the states we're doing the majority of their school-based testing right now. We're in New Mexico, we're doing in Arizona, we've been chosen in Washington State. I do a lot here in Hawaii. So I am open to answer any questions with both experience and with a reference and a background that goes on quite a bit. And I will always, I'll close with my decision in testing is always based on an individual because it's a medical process in my mind. It's not a testing process, it's a medical process.
Wow, so tons of experience, and thank you, Dr. Miskovich. I really appreciate that background, and I heard you say that it's a medical process, and you're a medical physician. So, can you tell us your perspective? Give me a little more about the schools you worked with. Why did they come to you for the testing solution, and How is it that they get these testing programs off the ground?
Boy, yeah, it varies broadly. Again, I think the reputation that we have as being fair, medically based, and then our price points are just ridiculously low, because I view this as helping the country. And granted, the biggest cost is paying our staff, et cetera. But I think they come for the quality, number one, and they are looking at the testing services that are available. We have been in 21 states, and we also work closely then with all of the departments of health. That's a real big issue I would like to throw out to the principals, that this is not just a testing event. Once you have a positive, the process now just starts. That person has, in your case, there will be parents or guardians that will have to be notified. And there can be lots of questions. That's why we always have a physician assistant, or a nurse practitioner available that will be answering those questions. Then there's the reporting. There's CDC questionnaires that have to be done. And there's reporting either to counties or to state departments of health, which are required by law. And we have, every one of them is a little bit different. So then we have to be reaching out and we have to be talking to them. So that's very important. And I'm sure we're going to get a lot of questions about how do you start the process? Like if a school contacts us and says, hey, we don't have testing, how do we begin, testing? And that's a whole nother lane we can go down if you would like.
Yeah, I definitely want to talk about how the testing is started and who does the testing. You mentioned having, some clinical practitioners in place to support testing, and it sounds like that's through your Premier Group services. But does that have to be the case, or can schools with the staff they already have also think about testing?
Yes, that's a really good point. When we go in, I think another reason that we have been successful is we service the schools. And so I would say there's 4 different models. Number one is we will come in, a school may have a broad number of elementary or school nurses or school aides, and we'll come in and we'll teach them. And we'll just come in and oversee what they're doing, teach them. We can actually help them and integrate our technology because we have a wonderful web-based technology, QR codes, many things that just make the process so smooth that have been used from all of these organizations across the country. So that's option one, if you're ready to go. On the far end, which is probably about 2/3, the schools are like, man, we are really challenged. This is way out of our league. This is complicated. They just get us for a turnkey. And so we bring in everything. We bring in the technology. We bring in the medical qualified people. We do the logistics. We do the planning. Many of them even have us do the tables and the setup. I mean, literally we can pop up in parking lots and do anything. So that's the far end. In between is a blend. Sometimes they'll say, well, we only have a few school aides, but we need more help. We'll blend in, we'll work directly with them. And then the fourth is like even a extreme hybrid where, like right now in Washington State, we have numerous schools that also want us to do their contact tracing, and they have us integrated right within their organizations, because that's another issue that schools are often saddled with, where they basically say, oh, here, you guys go do, or ladies go do testing, and by the way, your job is to track it down and figure which grades are affected and which students are affected and which family, and follow it up. That's complex. So we do have processes that we can help with them.
Wow. So it sounds like, it's flexible. So if
Yeah.
you have, staff availability, what you really need is someone to run the test and some training and the kits. And I believe you also need a CLIA waiver for most of
Yes.
these, and you're ready to go, which is a, 1 or 2 page document that we can find links to for anyone who's interested. But if you don't want to do all of that, there's also hybrid options, or, the full service turnkey that you mentioned, so that really, there's options to make whatever size of school, whatever size of staff you have, and whatever resourcing you have, you can find a way to make the testing feasible for your institution. Is that
Yeah,
a fair
Megan,
summary?
Yeah, that's a fair summary. Let me add one thing. Like, for example, when you have a district that may have numerous schools and they're trying to look for other options, some of them have also given us a secondary space to do it that might be centrally located, like a stadium parking lot, so that numerous schools will be able to come to that location. Most of the time we do it on location, but sometimes due to different dynamics, they also help choose a location that's better for their background. So that's also an option.
Well, and Dr. Andrews?
Scott, I noticed a good question in the chat. You mentioned contact tracing, and this person was saying that that's challenging, but I was wondering if you can describe, if you're already in the school doing some type of routine rapid testing, how then do you deal with someone who's identified as a positive or contact tracing?
Well, again, like I mentioned, sometimes schools are really armed and they're locked and loaded, and they've created numerous internal processes to deal with it. And so it depends on what's already established. In a perfect scenario, a school could have a bubble. And I know in elementary, that's really probably very, very challenging. And so what that means is that you would have a cohort of students, whether it's one class, that would be moving together that might not be integrating within the same grade or a grade above or a grade below. If that's the case, then your contact tracing can occur within that cohort. And that is done by push messages that the school may have established, whether it's web-based or old-fashioned paper that could be handed to the student, or all of the above. And then that takes you to a whole nother level of what testing within schools is all about. Because then a lot of times you may determine that that class is all determined to be close contacts, in which case you want to establish a new testing cadence for that classroom because they may have been exposed, in which case you may want to turn them to an every 3-day testing cadence until you can clear them as they go through that process. If it's broader, then you are trying to talk to the student and family and trying to see exactly, based on the classic now Johns Hopkins contact tracing class, which all of our people are trained through and more, then you just try to do the detective work to see how many contacts they've had. And very importantly, what we're seeing across the country is it tracks back to the home. It tracks back to the family. It tracks back to the friends. It tracks to their playmates after school. That's contact tracing. It goes well beyond the reaches of just the classroom if we really want to control the disease.
Thanks, Dr. Miskovich. And just to follow up on that, contact tracing means someone in the class was positive, so other students have been exposed, may be at risk. We know that without testing, the recommendation is to send everyone home for a 10-day quarantine, but I've heard you speak before about a couple other options, how to use testing to bring students back early and how to use testing to keep students in school. Can you describe that?
Yeah, it's a game changer now that's come out of the UK. And we have a UK model now that is trying to focus on how to keep in-person learning going on. And as Dr. Andrews just mentioned, you basically have the classic model is, you may say, well, oh, all of you were in that classroom and it was a smaller classroom and you had activities. So all of you kids go home for 10 days, get tested on your own, and then come back. Well, everyone can imagine you could really start emptying your classes out if you do that. So what the UK model is, it states, and it did a scientific evaluation, well-done study that basically had that same scenario. Let's say one student is positive in a class of 25. And instead of sending all of the students home, they left all 24 in, but then they did daily testing for 7 days on the 24 student cohort. And they found that they were effectively able to manage and keep the majority of all those students safely within the classroom for ongoing educational efforts. And the number of conversions, and again, there are caveats if you're having masks and other things that make sure that you're all working together. But they were able to do that model where they did 7-day consecutive testing, and that kept significant number of kids And the outcomes were similar. When it comes to positivity, spread, it still allowed education to occur.
So thank you. And it sounds like testing is a way to both make sure that you keep transmission from spreading while balancing keeping students and their teachers in school, but also keep the community safe and be aware if the spread may have gone on into the community through contact tracing. But can you speak a little bit to, with all of this contact tracing and reporting, is there any reason to be afraid? And do parents have to give permission to their schools to test the kids? And is there anything negative that would happen to a school if an outbreak were to have occurred?
Wow. All of those are home run questions. Number one of the biggest challenges we're seeing across the country is the effectiveness of each school on how they roll out the parental permission. Because all of the students will have to get a parent or guardian to sign. And so we have different ways we work with the school. We have an app that will push it out. We have websites that will push it out. The schools already, many of them have processes that they communicate. And we have found that there is a broad variation between effectiveness in getting students to be able to be getting the permission. And that's communication, right? How effective are you communicating the type of program that you are rolling out, right? Are you, explaining it factually, or are you just sending out something that is that is just a blanket that people might stuff under the seat of the car? But you really, nice little well done video is a great way to do it. Some people are doing brief town squares. I would highly advise, if you're going to do a town square, only take questions from the chat because they can get dominated by people who have various opinions. But a town square is a nice thing to do. It's up to, obviously, the principals on what they do in the schools and things like that. But communication is the key. The other thing I can tell everyone is expectations should be a ramp. As you get the startup, the word will spread, and how effective and how easy it is will spread, and your numbers will increase as time goes on. And then finally is the community. Based on what's happening in your community, the positivity rate, unfortunate death rates, et cetera, that's really going to change the numbers of people that may be interested in it. So, every community will have a little bit of a different pulse.
Thanks, Dr. Miskovich. I heard a really nice example the other week from a school system in Delaware, I believe, where they actually had a pre-testing pilot phase where they showed the parents what the testing was going to be like, just a nasal swab, not the one that goes really far up. And the parents actually were able to come with their children in the car. They drove up, just like a little drive-through. The swab was taken. I believe they gave a sticker or something for the younger kids, to say thank you. And they chatted through with the parents how they were going to run it in the school. And I know you mentioned that uptake seemed to increase over time, and the parents were very happy, and they rolled it out in the school. I think for the older kids, they had a little cart in the hallway, and the student just had to get up, go take their swab, drop it in, and come back. So it wasn't mass disruption to the classrooms all the time. And I've seen a few examples of little ones classrooms where they bring around the cart. I might be dating myself, but do you remember the fluoride carts where you would come and they would sign up to the classroom and give out your fluoride? And so the little ones would just be, asked to come up and have the swab and the sticker. And I've heard some cute jingles as well. My favorite has been 1, 2, 3, 4, switch to the other side, swirl some more for taking the swab. But, do you have any nice anecdotes of parents who maybe were on the fence beforehand and once testing was implemented, felt more comfortable after the fact that you can share?
Yeah, in Delaware, didn't they give all the parents a Maryland blue crab too when they went through? So,
yeah, too.
Yeah, that's real easy when you do something like that. Yeah, I do. I have a really good anecdote for that, and that is like in Arizona and New Mexico. What's happening is we're setting up programs where when there is that type of positivity that we've just described, they're actually letting the parents come in exactly the same scenario that you've described, Megan, and go through and get tested. Because remember, if you got that positivity, it can track up through. A lot of times it came from the family back through. They're inviting the families to come through in the drive-through basis. So we do this all the time, exactly what you've said. And it's referred to in the industry as strike team testing. So when you get a pretty significant breakout, like one of the schools that's close to me now, we basically had 3 grades that popped positive. Well, Saturday morning, we opened up the parking lot and we did a drive-through for all the parents and all the siblings and anybody that was exposed, because it was such a broad outbreak and it was still being tracked through. So basically, that's another way where you make it very community oriented and community based, and comfort is given when they all are part of the process and they see the process. Very important. You noticed, no, we don't do the NPs. We're doing the mid turbinates or nasal. So there's no question about the comfort right now.
Yeah, I heard somebody say, if you can pick your nose, you can take the swab. And I've known some kindergarteners in my day. They're very talented at that. So absolutely, I think it's good to get people comfortable. And it sounds like with the contact tracing, and I think you called it a strike team program, it's really about helping transmission stay prevented. It's not a punitive measure. It's not punishing the school for having had a positive in any way. It's about reporting to enhance safety. Is that a fair assessment?
Well, it's a great assessment, because let's look at the far end. The far end, and this is happening across the country, is there's such broad outbreaks that are occurring in schools that may not have, or may have all types of issues going on with some of the positivity in some of these states, counties, cities, boroughs is really high. So basically, they have to shut down. Now that's you want to talk about problems and publicity. I mean, that's what we are trying not to do in this scenario. So I think that's what everybody has to understand. This process is trying to keep what everyone on this call, I think, believes in, is that our children now deserve in-person education, and anything we can do to give them some normalcy in their lives to stop disruption is a very good benefit for the psychological aspects of these children and the parents. So yeah, I think it's all positive that we do this to keep it calm.
Yeah, absolutely. And is that still the case? I know that vaccines have been rolling out for the adults. We're starting to see some availability of vaccines in certain age groups under 18. Do you still need to test in those scenarios?
That's a good point. And actually, let me add on, I'm very experienced here because we are also a very large vaccine contractor across the country. So all of those places I'm talking about, we are now doing the duality where we'll do testing and vaccines right on schools. We integrate it right in. So that is another option that can happen for the schools, especially as we're going to be approaching November, when most of us believe we'll have Pfizer will be ready for shots in the arms. It is approved now. We need to get it out there. But I definitely feel that one of the things we're seeing right now with the kids, I think, we may see 50% of the country has the 12 to 17-year-olds that are vaccinated, and then we're getting some breakthrough infection. Let me just give a real brief overview, because in my media time, I always get asked about this, Megan. What is a breakthrough infection? And like, why get the vaccine and what's it? Well, first thing, the vaccine stops you from dying. Okay, the number of people who die that are vaccinated are just infinitesimal. Now, let me give you an example why the vaccine is effective and how we have to then use testing potentially. So you get vaccinated, you have this large army of antibodies now that are circulating. So you're going through whatever event you are, and you contract some COVID that gets up into your nasal mucosa or throat. It gets through the skin, gets into the bloodstream, maybe into the sinuses up here. And these antibodies start rushing in there and they start attacking it. Now, it's in your nose, it's in your throat, and it might cause a little bit of headache, a little bit of scratchy throat. You might get a little cough or something like that, feel a little achy. But what it does is it stops it from spreading systemically in most cases. It stops it from getting in and liquefying your lung tissue or causing a stroke or causing some other distant cardiovascular event. So it's doing its job. That's the difference. It kind of localizes it to minor symptoms. And then we're seeing that the symptoms are often going to go up and down and peak in about a 2-day period versus a much larger. Well, that's the key for testing. You have a window of a couple of days where you will then have a period where there may be some virus you can spread out of your nose, and people can be contagious during that time. That's why testing during that window with the antigen testing is very crucial, because you do have a period of time where people can shed the virus if they are tested. Now, they're then going to have a quick slope down, and they're going to have usually a very good outcome. Now, that window when you're not vaccinated can be a much longer window, and you can be up there in 4 or 5 days or even longer, depending on how your body responds immunologically to this. But that's the reason why we are often now, with Delta being so contagious and having some breakthroughs, we are testing pretty much broadly through vaccinated or unvaccinated.
So what I'm hearing you say is that these are really complementary tools, and we have to use every tool at our disposal to keep this pandemic mitigated, masking, social distancing. But since we want to have these kids safely in the classroom, vaccines are important. They work against severe disease, but you can still transmit the virus. You may have mild breakthrough infections if you're vaccinated, and to protect everybody else. And because of the strength of infectiousness of the Delta variant and the number of students who still can't be vaccinated or aren't yet vaccinated, testing is still very important, and so is getting vaccinated.
Great summary, Megan.
All right. Well, I just wanted to make sure I was tracking all of your expertise and what you were putting down there. But, what about beyond the classroom setting? How should schools be using COVID-19 testing? Does it make sense for sports teams? I know you mentioned that you were engaged with some of the Olympic testing. And if they haven't adopted testing yet, what would be your advice to schools?
Yeah, I mean, boy, you have hit me in my soft spot, sports. I've, between the SEC, where I had an office in SEC headquarters, and I got to go throughout the state. We were then broadened out to do other colleges, universities, and then I was called and consulted when just over a year ago, when the NHL had an outbreak. I was consulted, and I helped redesign the NHL's program and the NBA's program. And now we are doing numerous testings for the school sports. And I think it's important to highlight that, because basically everybody on this call probably understands that. I don't want to just say sports, but let's say sports and after school activities, drama, art, all of these, debate club or school sports. Those are important parts of the whole environment that we're allowing our students to participate in, is those after school activities that give them a way to find themselves. And so what we have found is that we have increased the cadence of testing depending on the closeness of the activity. And, one extreme might be wrestlers. Well, if you're going to allow wrestling to happen, that's a high close contact sport. You may want to kick up the testing on that one to 3-4 times a week. Yet, I mean, we're even testing the equestrians, but that's only once a week or twice a week extra. So testing for the sporting groups are very important. One of the things that we found is very effective is like a Monday, Friday surveillance testing for the sports teams, especially if you're an away team and you're getting on a bus and traveling to another event. Then testing before you get on a bus to see that people are safe. Now, again, this is really important for everyone, because both teams point the finger at the other team. We don't want you to give us the disease. So a lot of schools have come to the compromise that, say you have a 4 o'clock game or a 7 o'clock game, that by 11 o'clock every morning, both schools agree to full antigen testing of everyone that will be within range of each other. And therefore, what you have now is that 24-hour window, which is what is nice with antigens, that the chances, you're over 99% that you're not going to have someone contagious to spread it to the other team or to a close individual. So increased cadence of testing for activities is very important. And it can vary as we said, we usually break it into 3 bubbles, an A, B, or C, or 1, 2, and 3. And each one you can have graded by how close the activity is and the distance. And then I'll give you one final thing, outdoors rules. If it's outdoors, it is much safer than indoors. So that changes the whole dynamic also.
Dr. Miskovich, I'm thinking about sports. I think in some of the Olympic settings, there was rapid testing every day. I know that professional sports teams are often doing testing every day. Some movie studio settings, they're testing every day. I think we could agree that if you could rapid test everyone twice a day, you wouldn't miss anything, but it's not practical. So if we think about a middle school in a county somewhere in the United States, how does that school kind of balance the need to test versus the burden of testing? And how do they decide, you know, you mentioned twice a week, once a week. How should a school decide what's the right cadence?
Great question, Dr. Andrews. And I'm not trying to be boastful. We also do testing for all the Disney studios. And we are now doing testing for Netflix. So I'm very familiar with, and they have money to burn and they just test. And their comeback is, they miss a half a day of filming and that's millions of dollars. So they do that. So there is a cost consideration, right? We have to be honest about that. But that's the great thing about antigen testing is it compared to the PCR testing, much less expensive, and it gives us what we want, which is the contagious. So how do you look? I mean, we're probably having broad representation from different areas of the country, and some of you probably don't even want to go outside right now. You have so much COVID in your towns or cities or boroughs or counties, and some of you are like, probably saying, hey, that's old news, we're all doing better. Well, that's good information because that's what's important. A lot of it depends on what we call the local data that's surrounding you. And I'm going to try to highlight a couple of points that you're going to be able to find readily available, which could be things you could be looking for. Number one is your percent positivity. And what that means is in the region you're in, what percent of the tests that are being done and are publicly made available are positive. If you are up above 10% in your region, that means that there's not enough testing being done. Most of the time, the disease is still spreading. And most of the time, there's at least 50% more of the disease out there that is undetected. So if you are in a region with 10% positivity, and remember positivity, go for a 7-day period, not just a single day. But if you're in that kind of region, you should be testing more because that means you have probably more students in your classrooms that are positive and undetected. That's probably a minimum of 2 times a week if you can. And you pick the day, Tuesday, Friday, Monday, Thursday. If you have the luxury of a big budget, Monday, Wednesday, Friday is perfect for schools. That is just the dream of a school. As you said, Dr. Andrews, in a perfect world, like if you did antigen testing every day and we had antigen testing sitting home with mom who was looking at the children going to school and somebody had a runny nose and she's like, is that a cold or is that allergies or is this COVID? Here, Sonny, let's put some testing here and let's check, oh, it's COVID, you can't go to school, or it's negative, you can. So that is one of the options. Now let's go to the other extreme. Say your region has low incidence and low positivity. Well, then what on the lower end of the scale, if you're down there in the 2%, 1%, which is close to the disease being more controlled, then you can go to what's called surveillance testing, where you're trying to determine, is there any outbreaks going? Now, the lowest end of surveillance testing that we've designed and working with all the epidemiologists on our team is we'll take 25% of a school weekly and do 25% weekly. So over a 4-week period, everyone has been tested. That's an example of a surveillance testing. And then depending on the outbreak, it goes up higher. You have strike teams if they're positive. You have big drive-throughs, like we said. But again, if you're in the groups right now that are showing that positivity, then and the other thing we call is prevalence and incidence, or other epidemiologic terms, where you have a lot of disease in your area, then minimum everyone should be done weekly, including staff. I know we might talk about staff, but and twice a week in high prevalence areas.
Thank you. And I just want to remind the audience on this call that federal funding was provided specifically for COVID-19 testing in schools. And so we can direct you to the resources about that if you hadn't already been aware, to help make some of this more feasible. Dr. Andrews, I think you brought up a really good point about how frequently to test. And I know, Dr. Miskovich, you've been mentioning words like antigen and the price of antigen versus PCR. Could you tell us, Dr. Andrews, a little bit in simple terms about the difference between antigen and PCR testing and the advantages of each?
Sure. So PCR test is the main lab-based test used for SARS-CoV-2 or COVID. And the RT-PCR, which is the original and continues to be the standard for the FDA, involves cycling the RNA from the virus in order to amplify the amount that's there to test for it. So it's very accurate. But if you're doing a lab-based test, you have to get the sample to the lab and then batch process it, wait for the result to come off the instrument, which is usually not that long, a few hours. And then you have to get that result back to whoever ordered the test. In addition to PCR, there's 6 or 7 other technologies that are authorized under the EUA for lab-based testing. So PCR is just one of them. So the issue with PCR throughout the pandemic was the length of time to get the result back. And in the early days, in some areas, it was more than a week. It was averaging around 5 days. Now that interval is usually much lower, especially if someone's in an outpatient center or at a hospital. That result can happen the same day or at least by the next day. As Dr. Miskovich mentioned, that those tests that are done in the lab are considerably more expensive than point of care tests. But the real important feature of the point of care test is that the result is back in 15 minutes. So that allows you to isolate someone who's positive and stop the spread that way, and also to get the reassurance on the negative results. There's more than one type of point of care test now. Again, there's been a lot of technological advance during this pandemic. So the most common one, and the one that Dr. Miskovich has been mentioning, is an antigen test. In this case, antigen means a protein produced by the SARS-CoV-2 virus that can be detected by the test. Some of the antigen tests resemble pregnancy tests and can be read by the human eye. The BD test that Dr. Miskovich mentioned uses an analyzer, an optical analyzer, which removes the subjective reading of lines on the cartridge and gives you a clear positive or negative result. There are other types of rapid tests called molecular tests. They tend to be considerably more expensive than the antigen test. So if you have to do frequent rapid testing because you're trying to stop the spread and make good decisions, then the best choice at the moment is one of the rapid antigen tests.
Thank you, Dr. Andrews. And you mentioned that antigen tests are looking for protein, and I believe Dr. Scott Miskovich mentioned earlier a little bit about the infectious response that you get. Can you speak a little bit to why looking for that protein matters in terms of detecting infection that could be transmitted to somebody else?
Yeah, it's a good question, Megan. So the SARS-CoV-2 virus is an RNA virus, so it has a segment of ribonucleic acid. And when we do those lab-based tests, it's not finding the entire intact virus. It's going after a segment of the genes. And you can have that segment of genes present from a live virus or a dead virus that's broken up in pieces. So when Dr. Miskovich was talking about your antibodies swarming in because you've been vaccinated, and they're attacking that virus, they're chopping it up and it's no longer functioning. So a lab-based test might be positive because it's picking up those segments of broken virus, whereas the antigen test might be negative because the dead virus, inactivated virus, is not producing the protein. So then what scientists did was look at whether you could culture the virus, which is difficult to do. It has to be done in a special lab, obviously, because this is a dangerous virus. But they were looking to see if you could culture the virus, that would mean that the virus is contagious or infectious or transmissible. And they found very good correlation between positive and negative antigen results with positive and negative culture, whereas the PCR was more sensitive. It was reading positive when the virus couldn't be cultured, which we think is because it's either very low levels being amplified by the instrument, or it's detecting these segments of a virus that's no longer active.
So then the impact of that would be, if I understand you correctly, you might have a positive PCR test for a patient who can no longer transmit, whereas you're more likely to have a positive antigen rapid test when that patient or person, whether or not they have symptoms, can be infectious and transmit the virus to others. So in the school setting, you're mostly concerned about transmission versus clinical management. That's clinician's job, right? And so that antigen test is, beneficial. Is that interpreting you correctly?
That's true, but I also want to underscore what we said before, that if little Megan comes to the elementary school and she's infected on Tuesday and I don't get the result till Thursday, I now have an infected classroom of kids. But if I test her on Tuesday, I can call her parents and take action then before it's spread.
Fantastic. A couple more questions. I know we're getting close to the end of our time here. Dr. Miskovich, you mentioned choosing the BD analyzer. Could either you or Dr. Andrews share a little bit about what makes specifically the BD Veritor so easy to use?
There he goes.
Yeah, no, I can, because I'm the neutral party, so that makes it good. Well, Dr. Andrews is neutral because he's got an MD after his name, and his Hippocratic oath pushes him beyond anything. Yeah, I mean, I've used all of them. And one of the things that has been a beef about the others, which again look like the little pregnancy test, is what happens when it's questionable and blurry, and it puts too much human contact in there. And that's what we like about the Veritor. The analyzer is you pop it into the machine and it's positive or it's not positive. So it takes that away. It's real simple, as we mentioned earlier, to use in some of the school health aides or some of the people who are not used to doing some types of testing like that. It really does make a difference. Speed. The machine is very quick. The speed to get the results, the accuracy. Now you can have connectivity. It really makes a difference. But for me, number 1, 2, 3 through 10 is accuracy. That's what it's all about for me. Is the amount of how accurate it is with being, when it's positive, it is positive. There's very little question. We don't get many false positives at all. And you feel really, really good. If it's negative, it's negative. So our data has put us into the 99 percentiles. To give another example of something we did arrival testing at the airport on the Big Island of Hawaii, where we did about 500,000 of those for every arriving passenger consecutively, asymptomatic. And boy, what a great trial that was. And then anybody who was positive, we had a confirmatory PCR with them, which was the way the process was. So that was one of another big turning point for me, to have such a large sample size, which is, parallel to what a school would do. You're just screening everybody when they come through.
Dr. Miskovich, I just want to describe something for the audience, and then I think you can probably draw on one of those two examples to add to it. So just so we're clear where the 15 minutes comes in and why Dr. Miskovich said the instrument is fast. There's the swabby part, and then you put the swab in some liquid, and then you drip that liquid mixture onto the cartridge. And that's the beginning of 15 minutes while that cartridge just sits flat and it's maturing over that time. when it's time to do the reading, the cartridge is like a USB flash drive. You just plug it in the side. It gives you the reading within seconds. And the reason I've described all that is that you can line these up with timers. And so you're not 15 minutes between every assessment. You're able to do it very quickly. And maybe now Dr. Miskovich can use either the school or Hawaii Airport to describe how that can be efficient.
Oh, yeah. I mean, that's a really good point. So there's that little incubation period where you're letting it sit on the cartridge. And then basically you have our trained teams. And for example, when we did the Olympics trials, especially the finals, picking our teams, we would be doing 1,500 athletes and 500 staff. And in Olympic sport, it was like, they want that result now because they needed their little code to allow them to get into a region where, you know, they were free to go. And so we would just have lines of the machines going and the test would go and we would have trained staff and you would just be popping those things in every 8 to 10 seconds and getting the results. So yeah, that is a key, is you get a quality incubation period. But here's another thing I do want to highlight. That's why this is a medical process also, because you have to have the right infection control standards. When you have numerous tests lined up, there has to be the appropriate cleaning, there has to be the appropriate gloving. I don't care which test you're using, whatever tests in the country or world you're using, cross-contamination must be essentially evaluated in any of your schools. Or you get like the famous view, you could have tests that will come out positive that don't belong positive. So we have found also, I'll bring up one final point, is another organization has a machine. Oh man, it was so fickle. You moved it, it had to be recalibrated again and again and again. We found the machines now we have with BD are very reliable, sturdy. We calibrate them per prescribed, but they're spot on, and the mechanical issues are not an issue for us at all.
Thank you both. I feel like I have a much better understanding of the process from your descriptions. Last question, I'm going to change tracks just a little bit here so that we don't run out of time, and then we can take Q&A if we have any time left over. But we're coming into flu season here and schools have just gone back in session. How are teachers and staff and parents going to be able to tell the difference between COVID or the flu? And what is your recommendation for handling that?
Well, I can't tell the difference because the symptoms are all overlapping. There isn't even one symptom that's unique. Even the loss of smell is also a feature of common colds and influenza. So there's no way that the nursing staff or the teaching staff would be able to distinguish that. So what we're looking at now is combination testing that the FDA has given EUAs to in order to check for both. I'm not saying that's appropriate for the type of school testing that Dr. Miskovich is describing, because we never tested students at school for influenza. And the real idea on the school testing is testing both symptomatic and asymptomatic in order to stop the spread. But in general, we will see children and adults with symptoms being tested for influenza A, influenza B, and COVID. And also the flu vaccination shots are now available in a pharmacy near you. And flu season is coming, so now's the time to get the flu vaccine. The CDC did respond that it's possible to get the COVID vaccine and the flu vaccine, one in each arm on the same day at the same time, if that's what the person wants.
I can also make a comment, and here is the importance of this. If you're in a school and you have a health office, or if you don't have a health office, and a child presents with any type of symptoms, whether it is let's look at the common, the cough, the stuffy nose, the runny nose, the headache, etc. As Dr. Andrews said, I can't tell, none of us can tell. The only way we can tell is testing. So basically, most of the schools that we're working with have a policy where the child's sent home, and the child is sent home until they are allowed to return with a negative COVID test, right? So in that sense, I also have urgent cares that I run and operate, and medical practices, because we are a medical group. Basically, we're doing at this time of the year, we're doing combination tests, because if we get a test back and it's flu A, well, the child will return to school as soon as they feel better, maybe a day or two, but they're returning, which is different than a 10-day quarantine period. And as we described earlier in this event, now you've stopped the need for sending notice out to the students in the classroom, the parents, the families, the work. It really makes a huge difference to do a differentiation between flu and COVID from a perspective of the impact and the way it can travel through and create different problems.
Thank you, absolutely. So we're coming into the end. I just want to check with the team there. Do we have any questions from the chat that we want to pose to Dr. Andrews and Dr. Miskovich? Okay, I'm not hearing anything come through. And so, oh, no, I do have a question. We're hearing that testing for both is a great option. Is there any downside to doing both tests?
I don't see any downside. It's slightly more expensive, but it's really not all that much more expensive. And one of the things I do want to highlight is this is actually very hot in our literature over the last 7 to 10 days, because we're moving into flu season, is both. Some people have flu and COVID. So, identifying the fact that they may have both. Downside, I do not see any downside whatsoever. Another upside is if you're having some significant flu, we can use a medicine called Tamiflu, which can be given. It's like the antibiotic equivalent to knock the flu symptoms down. So opening up treatment is another positive I would like to highlight that is possible. But downside, I don't see any downside at all.
Dr. Miskovich, it occurs to me that we've talked a lot about students, but we haven't talked about teachers and staff. And I'll imagine that there are schools where some of the teachers and staff are vaccinated, but some have chosen not to be vaccinated. So do you have some general rubrics on testing vaccinated or unvaccinated teachers and staff?
Wow. This is a tough one. It's a good one. Actually, a lot of these are coming now down by orders from school districts, superintendents, and like, for example, in New Mexico, it's the governor who basically said, teachers, if you're not vaccinated, you're tested weekly, and so it's across the entire state. So it's going to be all over the map of how the determinations. But if you just look at the medical recommendation, which is what we make, it would follow and parallel every single thing we're talking about, I think, with a little bit of a kind of an edge and a push. Now, let me highlight something which I have been brought into teachers associations and had to give expert opinion on this. Lots of teachers will teach because they love it, and they'll teach in spite of maybe having a few advanced years, and maybe they're having a few medical issues. They can be at risk. They can be at significant risk. Remember, diabetes, hypertension, lung disease. We now have new data that show, again, a significant increase if you're a smoker, weight. So if you are at risk, or you have teachers that fit that category, or immunosuppression for whatever reason, then boy, you really want to make sure that those teachers have access to testing. And in our scenarios, if possible, we're recommending at least twice a week for those testings for their safety and health prevention, right? So there's two sides. You have the mandates that come from the higher ups, or you have safety. And the teachers, as we well know, multiple students, multiple cohorts, they're at risk. So I really strongly believe the teachers need to be tested, and they are being tested, and have higher risk, obviously, than students of having severe disease. And even as we stated earlier with vaccination, now granted, we are starting to roll out boosters with Pfizer for those in the high risk categories. But even as we progress on, if a teacher has been vaccinated and not boosted, they need to be tested. Either way, I would still be, we're having many districts just do weekly testing for teachers anyways, minimum, and more often for higher risk individuals.
Yeah, I mean, I'm hearing the symptoms between flu and COVID can overlap. We're still in the midst of the COVID pandemic. Flu season is coming, football season is coming. So I'm hearing that these tools are available, both the vaccines on the flu and the COVID side, hopefully soon for pediatrics, and on the testing side, and that they're complementary to one another and keeping this thing, in hand and keeping everyone safe and in school. Any last advice, if you haven't started testing yet, what's the first step that you would suggest to the audience to get started?
My first step is comes down to communication process internally. First, have your teams meet, understand what your requirements are, if you're required or not required. We talked a lot about contact tracing. Make sure you have an understanding of what are you going to do with the test, right? Have a policy and procedure in play before you begin any kind of communication of what does the result mean? How long will your students stay out? How long will a teacher stay out? How about the strike teams? All of those things we just talked about. But first, it's sit down with your leadership and communicate. And then secondarily, think of a solid medium, knowing your audience that you know very, very well, of how you're going to take the message you've just crafted to then give to that audience. And that's the key. As I said in the beginning, give a good, solid message, be open for questions, be open for challenges, be open for successes, and then be ready to pivot, be ready to be able to understand that your disease may be going up, it may be going down. You may have a school next to you that has no disease, and your school may run crazy for whatever reason. But then just be ready to have solid, almost daily communication about what you're going to do.
I can't top that, so I'll go on a lighter note, Megan. You said co-circulating viruses, pandemic, flu season, and football season, and it reminded me of elementary school. Which of these is not like the other? 3 are discouraging and 1 is something to look forward to.
Absolutely. And so on that positive note, Jackie, would you mind wrapping us up?
Truly my pleasure. This was so informative. I learned so much as an adult, a parent, grandparent, obviously an NAESP advocate for our members. Wonderful information. Appreciate the research, the history, the guidelines. So beneficial. So thanks to each of you for everything you contributed. We are very grateful to have you as a partner. So thank you to everybody. The webinar will be available to everyone archived. So if you didn't have a chance to finish it, we encourage you to share it with your faculty and staff members. Share it with your communities. Terrific resource. So have a great day. And again, thank you.